Hi, everyone, and welcome. We will be starting in just a minute. Just giving people a chance to join. Just want to thank everyone today for taking the time out to attend this session. I think that you'll receive some really valuable information regarding using a high-performing team to achieve integrated care. And also just very excited to have Dr. Eboni Winford with us today. All right, so it seems like the trickle of people has kind of stopped. So I'm going to go ahead and get started so that we can make the most of our time today. So again, just want to welcome everyone, let you know that we're very excited to have you here today, and just thank you in advance for attending our session. Like I said, I'm excited that we have Dr. Eboni Winford with us today. I will introduce her formally later. And again, she's going to be discussing how to use a high-performing team to successfully achieve integrated care. Next slide, please. My name is Shannon Lee, and I'm a Senior Program Manager at Primary Care Development Corporation, or PCDC. Again, just excited to be here with you all today and very much looking forward to this session. A few housekeeping items. We encourage your participation and just ask that if you have questions throughout the session, to please drop them in the chat. After Dr. Winford shares her content, we'll transition into the 30-minute office hour, and she'll have time to answer any questions that you may have. And just as an FYI, this session will be recorded and shared with everyone who registered. Next slide, please. So for those of you who are not familiar with PCDC, we were founded in 1993 as a nonprofit dedicated to expanding and transforming primary care in underserved communities to improve health outcomes, lower costs, and reduce disparities. Next slide, please. So I will read the disclaimer on this slide word for word. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, CMHS, the Substance Abuse and Mental Health Services Administration, SAMHSA, or the U.S. Department of Health and Human Services, HHS. Next slide, please. So last year, our theme for our webinars was operationalizing integration, and I just want to highlight the work that we did in this space. So this slide shows examples of our tip sheets. They were created, like I said, in support of last year's content. They speak to mitigating burnout through integrated healthcare, collaborative care management 101, maternal mental health from the perspective of that 30,000-foot view, and also ways in which you can provide equitable and responsive care to your patients and your clients. Next slide, please. So we continued our theme of operationalizing integration this year, and just want to highlight the associated tip sheets that we've done so far. The first you'll see here is from our first webinar in November. It provides insight into how integrated care efforts can help address the maternal mental health crisis in the United States. And the second one that you see, we are actually in the process of posting this tip sheet. This is from our last session, which was in January, and it focused on the integration of primary care and behavioral health care, highlighting lessons learned from the Iowa Pivot Grant, and it also speaks to the comprehensive health integration framework. So just as an FYI, all of these tip sheets can be accessed using the links found in this presentation or by visiting the Center of Excellence resource page. And so you'll be receiving the recording as well as the slide deck next week. And just an FYI that as we're able to update this particular presentation with the link from the January webinar, we will include it and make sure that you all have access to that. Next slide, please. So before introducing our speaker, we just want to know a little bit more about you. So if you could just let us know where you work, what your primary role is, and how you would rate your current skills and comfort with recruiting and retaining strong team members, and also evaluating individual readiness to implement integrated care. And I just encourage you, if you don't see your setting or your role listed here, please just drop it in the chat. We, always love to know where people are joining us from, what your roles are, and where you're working. So we'll give that a minute. And then also just as a reminder that once Dr. Winford wraps, we will transition into our half-hour open office hour session. And also today's slides and recordings will be made available next week. good morning to those who are in the chat. So good morning and good afternoon to everyone who's joining us from across the country. And I'm okay with us wrapping up the poll. Okay, so just a little breakdown. It looks like most everyone here is joining us from a behavioral health setting. We also have some from an integrated care setting and a few, about 6 from primary care. And just looking at some of the roles. So it looks like a lot of you chose other, but we do have some people in QI management, care managers, social workers, and therapists joining us. So wherever you're joining us from, whatever your role is, we are glad to have you. Please, just interact with us, ask questions as you have them. You really have a great opportunity to interact with one of the experts in this field who can help you as you're building that high-performing team. Next slide, please. So now I would like to formally introduce our speaker. Dr. Eboni Winford is the Director of Research and Health Equity at Cherokee Health Systems in Knoxville, Tennessee. She's also the Clinical Director for Cherokee Health Systems National Consultation and Training Program, which provides individualized training for community health organizations. And she's the co-founder of REACCH, which is Research and Education Aligned for Clinical and Community Health, a partnership between Cherokee Health Systems and the University of Tennessee Knoxville. She serves on national and local boards of directors and holds leadership positions in national health-related organizations. She is a Robert Wood Johnson Foundation Interdisciplinary Fellow, a Health Equity Scholar in Cambridge Health Alliance's Center for Health Equity, Education, and Advocacy, and an alumna of the American Psychological Association's Leadership Institute for Women. So again, you all, this is a real treat to have Dr. Winford with us to share this information with you. I'm so excited. I hope you all are as well, and just look forward to this session. And Dr. Winford, again, happy to have you, and I pass the baton to you.
Hello, hello. I was looking at the participant list, and I am happy to see some names that I recognize. So if I know you, hey, you can say hi in the chat box, but it's always good to see people that whose paths I've had an opportunity to cross in the past. Next slide, please. I have nothing. I didn't get paid anything extra to do this, so I have no financial disclosures for this presentation. Next. And just setting the stage, here's some things that I'm hoping that I can get across while we're talking today. But when we talk about integrated care, if you've ever heard me say anything, you cannot do integrated care unless your leadership supports it. And you can't do integrated care well unless you have a team that understands what integrated care is. And I just want to give you some peace that not everybody's going to get it at the same time, and that's okay. All right, but I'll give you some strategies to kind of assess where you are, where you want to be, and how do you get the right people on the team. So next slide, please. I want to talk about how leaders can demonstrate active support. And I just want to give you the caveat. I don't care if you have a C in front of your title, if you have an MD behind your name, a BA or a GED, don't care. There's leadership at every single level. And so I'm going to be talking about that from the perspective of the expanded version of leadership. But whether you are a formal leader or a recognized leader in your organization, these are things that we can do as we are looking to do integrated care and to really meet the needs of our communities as well as our team members, because we got to have team members to do integrated care, right? So we want to make sure that we address that. So I'll talk to you about ways that we can evaluate, excite, empower team members, give our time, and also give support. Next slide, please. When I'm thinking about evaluating, I'm thinking like, are you even ready for integrated care? Or are you even ready for any type of change? Next, please. And so I always like to recommend using like a SWOT analysis. It's real basic, but I promise it does some good stuff. So when we think about SWOT analysis, it's what are the strengths, and what's really important is that the stuff at the top are things that are internal to the organization. So that might be people, might be systems, might be workflows, might be processes. It could be the building, it could be technology, it doesn't matter, but what does your organization do really well? And then weaknesses, that's where you got to use the same labels. It could be people, it could be processes, it could be workflows, it could be procedures. What are some things that, or people, to be real, who are getting in the way of your team thriving and being able to reach the goals that you might have for integrated care? The things at the bottom are external to your organization. So if you think about opportunities, think about a grant, think about a training, thinking about, growing a money tree so that way you can have an endless supply of funding to implement whatever change you want. And then threats. These are things like laws, waiting on the budget to get approved, things that make it hard for us to actually make decisions moving forward. But in the end, like, we can huddle all day long internally, but it won't change those things externally. Next slide, please. And so when you're getting the information from the SWOT, it's really helpful to figure out, where are we now? Unanticipated question, but for those of you all who work in integrated care, if you've heard about the SAMHSA levels of integration, you have level 1, meaning we live in 2 separate buildings in 2 separate worlds. We sometimes look at each other, but we never speak. Level 6, meaning we share everything, including patients, panels, electronic health systems, whole 9 yards. What number are you if you were anywhere on that spectrum? And you can use the chat box. Three, okay. That's the typical response I see. 3, 3.5. Oh, I knew somebody was going to be a 0.5 or a non-whole number. I appreciate that. 4, good. Okay. Where do you want to be realistically? Where do you want your organization to be in terms of levels of integrated care, levels of good, strong teamwork? Okay. A level 5, 4, good. Who's going to give me like a 3.75? Want to be a 5, good. Perfect. So you can start at a 3 with an aim to get to 5, but I want to tell you right now that you can attend all the trainings you want with me, but you will not go from a 3 to a 5 tomorrow just because you listened to me today. And so we got to be really, really realistic about what change means depending on where you are now, what your strengths, weaknesses, opportunities, and threats are. But also just be real. What are the things that get in the way from you moving to where you want to be? But also, what are the things that can get you closer to where you want to be? Next button, please. I argue that leadership can make or break you. So if you have good, strong leaders who support your initiatives, who want good, strong team members, who allow team members to make decisions without needing permission for everything that they do, you can get closer to that 5 than if you have leaders who don't get it, who don't support it, who don't understand it. And you yourself may be that leader who doesn't get it, doesn't understand it, doesn't support it. And so that could be a barrier to the organization moving forward in its ability to implement integrated care, to strengthen and have the highest performing team possible. Next. If you hear a child screaming in the background, I am in a primary care clinic. That's where I work. That's how I roll. And we do give vaccines here. And babies don't like that. And so I promise we're not intentionally hurting anybody, but if you hear it, that's what's going down. All right. Next, we want to excite everybody. Like, when you're thinking about making a change, whether it's to bring on new team members, right? Like, maybe you have never done, listen, I'm not hurting the babies, Debbie. Like, I promise we're trying to make them healthy. Okay. But if you want to bring on new team members, introduce a new type of service, if you want to transition from a 3 to a 5, I really recommend like hyping things up, getting really, really, really excited about it. So that way people are like, huh, what is this thing? Like, I keep hearing about this. I keep hearing about this person, this new team member, this new thing they can do, but like, what the heck is it? Next slide. So we recommend hosting a kickoff meeting, right? Where literally everybody in your clinic gets to show up. So C-suite, get a nurse champion, primary care champion, a billing and coding champion, because they are members of your team. If you want that really good revenue cycle, right, you need somebody who understands the model of care that you're providing. And if they don't get it, they won't know how to make sure that you're getting reimbursed the highest amount that you can for what you've done. If you have behavioral health, you want a champion who's going to brag on working on a team and how awesome it is to have a team member. Clinic operations manager, right? Those are the people who are going to handle the processes, the workflow. If you have a problem, you'll probably go talk to them and they'll help you resolve it. IT, I'm going to push pause for that. You cannot do healthcare, whether we're talking integrated care or siloed care, well at all, unless you have a good, strong, like health record file or a health information or electronic health record. You can't do it. And it's just pretty bad. Okay. We want to make sure that we remember that when we're thinking about integrated care, that the patient is the most commonly underutilized member of the entire team. So that could be somebody that falls under the who else. Like if you have like a patient advisory board representative who can be present and give their feedback about the changes that you're hoping to make and things like that. Okay. Front office champion. Can I tell you that, like, I don't think we give enough credit to our front office staff, and they can be some of the strongest team members ever. I like to keep my front office staff, I like to keep their drawer full of chocolate, like full of caffeine, full of anything that, like, when it's a rough day, they can pull out one of those, pieces of chocolate and read one of those little corny motivational speeches on the wrapper, but like they will get chocolate from me all the time. Because I don't know if you've ever worked in the front office where like the phone is ringing and a person's at the front desk and then we're sending messages to them asking them to reschedule a patient, but can they also run the insurance for this, but then can they also fax this and then make sure they get this and send it to the right person? They have to have like octopus hands in order to be really effective. So they have to understand and be okay with any changes that are going to be implemented in the delivery of care. We want to make sure their voice is heard. Because if not, like, they're those leaders in the front. They are the leaders in the clinic. If they don't buy in, like, it's going to be real rough. Okay. Even if you want to revamp, I've had a lot of requests, especially this year, last year. Everyone apparently was like, listen, the pandemic did us dirty. We have no idea what model of care we're operating under. Like, we're just showing up, but we want to make sure that we go back to how we were before. We want to do integrated care. How do we do integrated care again? I recommend a kickoff meeting to revamp as well, like to reintroduce people to what integrated care is. I'll give you an example. I'm at Cherokee Health Systems and all we do is integrated care. We train on integrated care. We teach on integrated care. We provide integrated care. But just this morning, I did a training with 6 of our advanced practice nurses who have been here for like 2-3 years, who are also like struggling to utilize the integrated care model internally, right? Because they started during the pandemic. It was just a really weird version of integrated care, to be honest. And so this morning I did a 1-hour like stump the chump where I said, all right, here's what integrated care is. Now tell me what questions and concerns you have. If nobody knows what Stump the Chump is, NPR used to have the Click and Clack Brothers show where you would call and say, hey, my car makes the sound. And they would say, oh my goodness, it's your carburetor. I don't know how they knew that, but they could hear the sound and tell you exactly what was wrong with your car. So we like to do that internally. Tell us the problem you have. And whether we've heard of it or not, we want to help you talk it through while you're here today. So we did a Click and Clack Brothers Stump the Chump just this morning. And some of the providers were like, I did not know you could do that. I didn't know that I could use the team that way. I didn't know this. I didn't know that. So yes, reinvigorating and having a kickoff meeting, a retraining, absolutely important. Next slide, please. What do? You brag. Y'all see how excited I am? Like, this is my baseline, like to be hype like this. But when I am talking to people about working on a team, about working in integrated care, I can't be like, listen, like you're going to hate it, but I'm supposed to tell you that it's going to be real good. I can't do that because why would you have any confidence in a change? Or why would you have any confidence in working on a team in a way that you may not have ever worked on a team before? I tell people, yes, this will be weird. It's going to be uncomfortable, especially if you've never worked this way before. With the providers I met with this morning internally, I was like, y'all are going to think I am losing it when I tell you what integrated care can really be, right? And so if you're anxious about what this is, guess what? You're doing it right. It's okay. Like, take a deep breath. We're going to get through it together. But I like to teach whatever the clinical model is that you want to implement. Okay, share evidence, like it works, and evidence doesn't have to be just numbers. I had a primary care provider that I've been working with for the last like 8 or 9 years also attend the call with me. And I'll tell you that I'm a psychologist by training. She is a family nurse practitioner by training, but she has way more street cred when talking to other primary care providers than I ever will. So she shared anecdotes about how we've worked together and how working as a team has alleviated some of her burden, helped her to get more things done. But brag a little bit, like it's totally okay. Make an action plan, because again, nobody up here, as awesome and amazing as this training might be, you will not get from a 3 to a 5 tomorrow. So you got to make a plan. What's one small thing that you can do differently to move toward your goal? Okay. Show enthusiasm and express hope. You know, I'm gonna be real open and honest right now. We have a new scheduling system that is set to start in 7 days. We are all anxious, like so anxious. Like I don't think I've seen the system this anxious in a minute, because it's something entirely brand new. And so all I've been saying is, yep, it's gonna suck when we first start, but what can we do to get through it? Like, how can we make it work? What tips and strategies can you share when you find them? But just anticipate feeling clunky, anticipate being anxious, but guess what? We're gonna get through it, okay? And I like to just say, yep, you're anxious. Yep. There's nothing else for me to say, but yep, it's true. I'm going to validate that experience for you. Um, if you're moving from like different levels of integration, for example, I think it's really important to discuss the qualitative differences in the care models. That way everyone has the same expectations about what team members should be doing, or what they could be doing, how they should be functioning, or how they could be functioning at their highest level. But anything that just sets the stage, beautiful, okay? And encourage feedback. Like, as you implement this new thing, tell me about it. Like, what went well? What was really awful? You never want to do that ever again. Like, tell me about it, because I bet somebody else had a similar experience. Next slide, please. And so we want to empower people. This is like the coolest part of the team building, is like actually selecting the people who get to come on your team. And so this is when you get to hand pick the interdisciplinary team. It doesn't just have to be one hand doing the picking. Like, we do all of our interviews, like a person who comes to interview here might meet with like 7 people in one day. And then we all huddle at the end of the day, and we all give our own perspective about what we saw, what we observed, because we want to be mindful that we see things differently depending on our discipline, depending on our life experience, and depending on our organizational understanding and history. So we get to handpick who's going to be a good team member. And so I'll share with you some of the strategies that we look for and that we utilize to find that team member. Next slide, please. So you heard me say already that there is leadership at every level. I put the front office at the top because, again, I have filled in for front office staff before because it just got hectic. And I was like, listen, you go take a break for 10 minutes and I will sit here. And I will be honest, I regretted those 10 minutes of offering the help because it was so hectic. And they can have literally anything they want from me because their job is hard. And I will never underestimate that ever again. So they are leaders. They help me here in the primary care clinic know what's helpful as far as how much paperwork to provide when a patient checks in. At what point should the paperwork be provided? Are there certain things we can give electronically? Like, these are the things that they've observed from working. That's all they do is work in the front. So I'm going to take their guidance and their experience and their leadership to help me inform how we might develop a workflow in the clinic. They are leaders, whether they have leader in front of their name or not. They know that front office, and we want to recognize and give them what we call designated authority. If they notice that a check-in procedure is not working well, they should not have to call the IT person, who will then call the COO, who will then call the CEO and say, hey, can we give them this paper instead of that paper? They should be able to do it with no repercussions because they're doing it to improve how the care of our patients is given, okay? Nursing. Y'all, if you are a nurse, raise your hand if you're a nurse. Drop it somewhere in the chat box. Like, tell me if you're a nurse. All right. Hey, Debbie. Let me tell you, nurses and front office staff. Yes, I love the hearts. I'm here for it. Yes, beautiful. If nobody is giving you chocolate today, like I'm gonna need you to request it because y'all deserve it. Chocolate is my love language. But let me tell you, front office and nursing are the real MVPs. Dark chocolate is my favorite, Kathleen. I got you. They're the real MVPs of this whole healthcare system. Air traffic control. I think that for me as a behavioral health provider who works in primary care, I don't do anything in an exam room until I check with my nurse first. I'm not asking for permission, but I'm asking for information. Also, nurses have to be personable because they spend most of the time with our patients here. They're the ones that get the pictures of the grandbabies and the nieces and nephews while they're doing the vitals. They can tell you, like, I know they said that like all they're here for is diabetes, but they were crying when they told me about it. So you might want to check in with them. The clinic I'm in now, we have good longevity. Like we've been working together 8 to 12 years here in this one clinic. So our team is strong. We have the knowledge of both a gift and a curse sometimes, but sometimes we can come in having heard of things that happen over the weekend. And we know when the patient comes in the clinic, they will have been affected by it because of what we know about the community, because, you know, we are so connected in the community. Nurses are typically the ones that say, y'all, when this person comes in, you might want to ask about that because this happened this weekend. It could be good, it could be amazing, it could be really bad, but they're the ones that give us that information. They're like our cultural brokers in a lot of ways. They are the Walmart welcome people. Like, come on in and let me get you signed up. Okay. Give them designated authority. Here at Cherokee Health Systems, the nurse does not have to ask permission of the primary care provider if they can tag in another team member to meet a patient's need. They tag in that team member, the patient comes in, you meet them there, and then you collaborate and coordinate. The nurse will talk with the PCP and say, hey, I had the BHC go in first because of XYZ. Again, they are allowed to do that without repercussion. We give the designated level of authority at every single level of leadership. Behavioral health, we have 2 regional behavioral health directors of operations. Like those are the ones that if something's not working from scheduling, something's not working from workflow, we just tell them like, hey, I tried it this way, you might want to share it, or they give us the new rundown, like here's a new system we're using, let's work it out. You got to have medical buy-in. Like I said, when I did the training this morning, I had my colleague who's a FNP who has all the street cred in the world. So any changes that you're making within like a medical setting, you better have somebody who has like a medical background talk to or be on your side, or else people will give you the side eye like, I don't know you like that. So they give me street cred and we want to give them designated authority. They don't have to submit a referral or an order and wait for me to approve the referral or an order before I can go in and see a patient while they're already in the clinic. They can tell a patient without me even knowing, I'm going to have Dr. Winford come in and meet with you because she's an expert in depression management and she's going to help me help you. They then come and say, hey, can you go meet with the patient I just told you were already going to come in and see? Absolutely, right? Like we don't have to ask permission. They know how we roll. Our team has worked well together. We just do it. And then there's operations. They're the ones who truly make the operations stay together. And so, of course, we need levels of leadership there. So like I said, we have our regional operations directors, we have a COO, we have a deputy COO, we have office managers, like whole 9 yards. Like we don't want people to have to just talk to the COO if they have a recommendation or a question. There are people along the way that they can collaborate with. Next button, please. This is a great opportunity for some more strategic planning. Strengths, weaknesses, opportunities, and threats, or where are we now? Where do we want to be? We had a change in our organizational structure recently. Our very first CEO, Dr. Dennis Freeman, passed away in August of 2022. And we had our second ever CEO since we opened in 1960. Okay. And so that became a good time to reevaluate the vision of the organization. Like we've come this far. Do we want to continue along this path? Do we want to add extra things, like change things? But it became a really good way to figure out how do we do this. And within the last 2 to 4 years is where we found so many opportunities for additional leadership levels. So we started having a billing coding Like director of billing and coding, we have a revenue cycle manager now. We never had that before. We would just send it off and be like, I hope we get paid. But now we have somebody whose job it is to literally monitor those things and give us feedback about things we could be doing differently or things we did wrong and we need to never do again because that's not cool. We have people scheduling. We have somebody who is just in charge of the templates of making sure the appointment types are good, whole 9 yards, right? But that person doesn't have to ask the COO if they have permission to change a schedule if it means more patients are going to be able to be accommodated that day because of the change. But these are people we never thought we needed a director of scheduling or a director of clinical workflow. Like nobody thinks like that. But when you really sit and think about what's missing, that's when you start looking for people who have like the good, strong characteristics to get it done. Next slide. So who are those good people? I will tell you this, and anybody who hears me talk, I will hire you for fit and then teach you the skill, okay? Because if you don't fit, I don't care how many degrees and how many books you've written or read, like it's just not gonna work. I have been able to tell within like the first couple minutes of an interview whether or not somebody's going to be a good team member or a good strong fit, someone who it's worth recruiting because they're going to help us to elevate, or are they just going to bring stuff down? One of my favorite questions, and I'll give you some sneak peek questions on the next slide, but for now, one of my favorite questions to ask people is, tell me about a time when you had to be flexible. My all-time favorite response, insert sarcasm here, was, a patient showed up 15 minutes late and I still saw them. And I was like, it is so nice to meet you. Let me show you out. Because that's not a good fit for the type of patients that we provide care for. You know, I was meeting with some colleagues for another research project, and we were looking at the bus stops, which are clearly visible across the street, and we timed it. It took 30 minutes before the first bus came. And if patients want to get to the pharmacy that's closest to this location, it's 3.8 miles away. If I were to get in my car, tops 10-minute drive. And that's if I hit every single red light. If I were to take that bus that they waited 30 minutes to get on, it would take an hour to get to that pharmacy. That pharmacy happens to be one of our clinics that has primary care in it. So if I know that about a patient, they've waited 30 minutes, they sat on a bus for an hour, and they still show up just 15 minutes late for an appointment, you better believe I'm gonna pull them back because I didn't have to ride the bus or wait for it for an hour and a half. The fact that they did not give up, the fact that they showed up, you better let them come back. Like, that's where the equity piece comes in. Like, I get really mean real fast. Like, what do you mean you're not going to see the person? Like, you better see the person. You have no idea what they did to get to you. 39% of our patients have Medicare, 30%, let me take it back, 30% have no insurance. We did not expand Medicaid. 39% have Medicaid, and the remaining 32% have Medicare. We are dealing with people, for me, who live at, below, or around the federal poverty line. How dare I turn them away because they showed up 15 minutes late? They showed up. Now I can keep in mind, like, you got people who try to play you and they will come late every single time. And that's when you just talk to them like, listen, I know what you're doing. I'm not here for it. Let's work this out. But for someone who makes their way in, I'm gonna see you. And if you have team members that tell patients, no, I won't see you because you're 15 minutes late, I don't want you on my team. Like, I honestly do not want you here. Okay. So we got people who are the right people. They're committed to excellence. Now, keep in mind, like, the enjoy change thing can be very flexible. Okay. Like, I don't enjoy change, but I don't fight it that much. Like, I get with it. I find that silver lining. I'm like, you know what, y'all, let's just do it. Who knows? You know, it might work out, it might not, but let's do it. But if you have people who are like, I'm not doing it because we've never done it that way, why would we change now? Like, ugh, you won't hear that from me, right? We are attentive to details. So we're thinking about the bigger picture while also being mindful of the individual person. Flexible. My very first supervisor ever in life told me something that I share with everyone. Blessed are the flexible, for they shall never be bent out of shape. And if you want to be a good, strong team member working in a healthcare system, especially if you're working toward integrated care, you better know how to bend without breaking it. hone your inner rubber band or your inner slinky that used to like hop down the stairs, like get all of those things. You actually got to like working with other people if you're going to be a strong team member. Like, we need you to like people. You know, some people don't like people. I'm like, why are you here then? And I know this sounds real basic, but you got to know how to use a computer, or at least know how to work with somebody who's a scribe, because the way healthcare works now, it's fast. Okay. The not so right people are the ones who are inflexible, risk averse, like they're afraid to try anything new out of fear of failure. They are protective of their turf, meaning this is my patient. You didn't ask if you could see my patient. I can only determine who sees that patient in what order. Like, I don't like working with people like that. And typically they don't stay long. So if we're thinking about retention, people on the right side, the not so right side, are the people that we do not retain. And so I'm really looking for the fit on the left side under the right people, because those are the people that will retain. Again, I'm in my 11th year here. The primary care provider I work with primarily has been here for 13 years. Another PCP is in her 9th year. One of our case managers has been here for another 12, 13 years. We've had people come, go away, do something else, and come right on back. Like one of our lead nurses, he left us for like 3 years and was a flight attendant and came right on back. Like, this is his 3rd time working with us, and he keeps coming back. Like, that's still retention because he knows the door is open. But he has all the things on the left side. The people who are on the right side, who want it done the exact same way every single day, they don't really work too well. Okay, next slide. And FYI, I know I probably stepped on some toes because some of you all are on the right side, and that's okay. That's okay. Next slide. How do you get the people on the right side? Next slide. All right. This is just for behavioral health. And when I'm working with people who tell me that they have workforce recruitment difficulties, I always ask this: let me see your job description. What's your job advertisement? Because you will get what you advertise for. And so in integrated care, our approach is, as long as you can be credentialed in this state, I don't care what license you have. Okay. So if we look on the left side, if I'm advertising for a licensed social worker who will function as someone who does therapy and primary care, what do you think I'm gonna get when somebody submits their application as a licensed social worker for someone who does therapy and primary care? I'm gonna get somebody who wants to do 50-minute therapy in a primary care office. And if that's not what I really want, I don't need to advertise that way. If you want somebody who is, and for all intents and purposes, a primary care provider who happens to have a license as a social worker or a psychologist, you're going to lean toward the right side, where you're looking for someone who's a behavioral health clinician. They will work alongside the primary care providers to promote whole person care. And notice that the requirements, any degree, as long as you're license eligible. Prior experience in primary care is preferred, but it's not required, because remember, I will teach you the skill if you have the fit. Skills: high energy, flexibility, strong communication skills. These are like words from our actual job description for team members. We want to make sure it's a good fit, because if you want a good, strong team that you can hold on to for a while and that won't go through like loop and loop and loop and loop and all this turnover, you need those good, strong qualities. Okay, next slide, please. The interview is where you find the people. And again, I can tell you within the first couple of minutes whether or not you're going to fit. Yeah, there's no ideal personality, but you know when it's the wrong one. Like, it comes across very strongly. So you want someone who's, you know, optimistic, values working in groups, they're conscientious, like they share your values, they share the organizational values. Like, we're committed to equity, diversity, we're committed to removing any barriers that contribute to disparities. And if that's not your thing, then this ain't your job, just to be real. All right, next slide. These are the things that we look for, and I kind of mentioned that already, but you'll get these slides so you can have this information moving forward. Next slide. You got to balance the team members. You know, Google did this study where they looked for the elements of the perfect team. And surprise, there's no perfect team, but there are certain things that you look for, right? So some people are results oriented. Some people are relationship focused. Some people are process and rule followers. Some people are disruptive and innovative, and some people are pragmatic. What do you think it would be if like you only had a team of results oriented people? Who cares about the people as long as we meet the bottom line, right? It'd be real boring and harmful if you're real. What if you only had people who are relationship focused? Would you get anything done except for hugs? Probably not. If you only had disruptive thinkers, we would have to have a bail fund to get people out of jail because they just be disrupting everything, right? We'd be talking all day in circles, like how do we, how do we disrupt this? How do we dismantle that? It's like, what we gonna do about it, right? We can only talk but so much. If you only have people who follow the rules, then you never have room for innovation or creativity because if the rule isn't written, then of course you're not gonna try it. And then pragmatic. Yeah, you want people who are going to challenge the new ideas and help you look for like the blind spots and loopholes, but you don't need somebody who's like, listen, we did that before, it was stupid. Thank you. And what can you contribute to this discussion? So you want to find a good balance. There's no ratio, like you need 2 results oriented, 1 pragmatic, 1 relationship focused. It doesn't matter, but you can see some of the limitations if every single person on your team has the same type of characteristic. We need balance because that's how we build that strong, high functioning team. Next slide. Here's some of my favorite questions to ask people. During the interview, some of you are like, what do you do? Well, here's what I do. So tell me something about yourself that's not included in your application or your CV. I have found out people bake bread, they like to hike, they like to climb. A lot of people play an instrument, just all the cool things that they do. Now, it's also interesting how they answer that. I promise it's not a projective psychological assessment, but like the way they answer can be real fun. They're like, well, I forgot to say that it only took me 3 years to finish my degree. And I'm like, I saw that on the numbers, but thank you. I want to know about like you. That tells me more about you. One of the things I say when people say, tell me something that's not on your CV, I brag. I'm like, listen, y'all, I got 21 nieces and nephews and 2 godchildren. Like you will never see that on my CV. I'm like the best auntie there is. I will never birth a child, but I will be the child's auntie forever. And I love that. Like any child that comes near me gets adopted. Auntie Eboni comes around. You can ask anybody, right? But that's something I want you to know. Like I care. Like I will bring you in, right? Like I'm gonna make you family, even though I'm very results oriented at the same time. Tell me about a time when you had to demonstrate flexibility. Do not tell me you saw somebody when they came 15 minutes late. Okay. Yes, Auntie Ebony. I love Auntie Ebony. Describe your ideal day. So whether you're talking clinical, whether you're talking operational, whether you're talking front office, like what's an ideal day? I know someone's not going to be a good fit if they say things like, I really just want my schedule to look exactly the same every single day. I only want to do this at 8 o'clock and I only want to do this at 12 o'clock. And if anybody asked me to change that, I wouldn't be able to function. I'm like, it was real nice to meet you. Let me show you how to get out of here. Okay. Favorite question. How many lemons can you fit in a limo? Hey, Shanistelle. I know her. But how many lemons can you fit in a limo? Like somebody give me just a random answer. What do you think? 1,000, 25,000, 450,000, 0, a whole tree. Depends. Kyra, you win. Ding, ding, ding. It depends, right? I want somebody to tell me, well, I don't know. Like, can you slice it? Can you juice it? Is the window rolled down? Right? Like, is the sky thingy open? Whatever that thing is called. Is it a stretch limo? Yes, Georgette. Like, that's the person I want to hear from. Who's like, I don't know. I think it depends on if the doors are open or not. That means they are going to think outside the box, the actual literal box of the limo, right? And they're going to just really just test the waters. Those of you who said 4,500,000 million, I like you too, because that means you're going to work to make sure everybody gets a little bit of something. But I really love it when people are like, can I change the form of the lemon? And I'm like, ooh, tell me more, right? I really am drawn to people who go that route. I care about how people manage conflict. And then I will give a clinical scenario that describes my typical day and then ask you to respond to it. it's not fair and it's fun. I'm gonna just be real. Like when we're interviewing like interns who are like their last year of school and I give them like a real life scenario, they're like, wait, what? I'm like, I promise you won't do it alone. I'm gonna be there with you the whole time. But what would you do if this happened? Because it will happen. And to see them from that interview to when they finish, being able to just like handle that situation, so good. Okay. Next slide. So time is another way that leaders can demonstrate active support. Next time, not next time, next slide. This is just real basic, and these are for people who do have like leadership and authority, particularly those who are managers. This is helpful for retaining staff if you engage in coaching. I love it when, you know, it may be called precepting, where an intern, for example, will go see a patient. And before the patient leaves, I say, come talk to me, present the case to me, let's talk it through. And I'll say, have you considered this? And then they might go in the room and be like, yes, when I said that, it worked really well. Okay. Shadowing both ways. I shadow the people I train, I let them shadow me, and then we talk about it. Like, what did you notice I did? What would you have done if that happened to you? But really devoting that time and being there with them, being in the trenches with them, problem solving. If they come to you consistently, like, I have an intern who has never left at 5 o'clock and she started with us in July. Her goal is to leave by 5:01. And so we talk every week about what can we do to get your note documented this way, or how can we do this? How can we do that? Because if I'm not teaching you how to balance your time in and outside of work, then I'm not teaching you right. Because I want to retain her. I don't want her to burn out and give up. Like, I need you to go home. So let's problem solve ways to overcome the barrier that you have with, you know, going home when everybody else does. And then role modeling. I think that is so important, especially in times of conflict. How do I respond to high stress situations? Do they see me doing that? And can that be something that they can then implement and do? And so we call this leadership rounding, you know, because I firmly believe the higher up we get in an organization, the further away we get from like the real deal work. And sometimes we, just to be frank, we need to touch grass. We cannot be making recommendations and rules and changes for a clinic or an organization when you have never or haven't stepped foot in it in the last 3 years. Like, that's not okay. The higher we get away from the day-to-day grind, I think the more we get away from it. And so this leadership rounding is an opportunity to get back in the grind. Okay. We have a mobile clinic. I go out on the mobile clinic at least once a month because I'm the BH lead for the mobile clinic. I usually do most of the visits via telemed, but I need to be out there on the street with them at least once, you know, to figure out how's it going, what's going well, what's not going well. And so I try to get out there at least once a month, and I see patients face to face. I'm on the street with them. If we're doing street medicine, I'm out there with them because I can't make changes for them unless I'm doing it with them. And that's a key thing about time and leadership. You have to do it with them. Okay. That's also retention, because people will start to resent you if all you do is make changes, but you're not there to implement the changes or to figure out like the consequence of the changes. You got to get in there with me. Okay. Next slide. And then lastly, support. Next slide. All right, y'all, roll with me. And so whoever's advancing the slides, we're going to do one click at a time. Okay. But no clicks just yet. Go back. Go back. Okay. So I'm going to tell this story through cell phones. Okay. So you can go ahead and click the button now. All right. Motorola, back in like the late 80s and 90s, they were like, y'all know what would be so cool? If people could talk on the phone without being in their house or without having to go to a payphone and find a dime or a quarter. You know, it'd be really cool if we had a car phone. So Motorola created this car phone that used to come in the leather pouch. It had a handle and a zipper, and it was like this big on your ear, and it had a cord that you put into the cigarette lighter in your car. Now, growing up, we thought we were cute because my mama was like, oh my goodness, I need me a car phone. And so she talked to my dad, and my dad was like, babe, anything for you. So she got her a car phone. Now, keep in mind, we had us a Pontiac Firebird when I was growing up, and it had T-tops, not like, you know, the thing that comes at the convertible top. No. We had T-tops, meaning you could take the top off and like the wind would just be blowing through your hair and you could not tell us it wasn't cool. It was very uncomfortable, but we would never say that, okay? But we had our T-top Pontiac Firebird. It was maroon, and my mama would plug in that cigarette lighter charger and we would go visiting, okay? So we were like, let's go visit grandma. So we pull up to my grandma's house and my mom's like, hey, mom, guess where I am? And my grandma's like, where? And my mom is like, I'm outside. Pardon my French. Why the hell are you out there? Come inside. That was my grandma. Like, she did not play. She's like, why are you out there? And so my mom was like, that didn't go the way I thought it was supposed to go. So she's like, let's go visit your auntie. So we would go visit aunties and she's like, hey, sis, guess where I am? I'm outside. And then my aunties were like, oh my goodness, let me see. And they ran out and got the response my mom wanted. All that is to say is that Motorola was an innovator. My mom was an early adopter. Next slide. And so eventually she was like, yo, this Motorola like car phone is cool. But I saw that they have these phones that are like flip phones. They got a piece of plastic that covers the, the keypad, and this piece of plastic that if you pull it up, they call it an antenna. It's supposed to make your, signal be better. But like either way, like I saw that Motorola upgraded from the car phone to the flip phone. I need it. So my mom is getting the flip phone, and now my aunties are like, wait, you don't have to keep that plugged into your car? Like you can be outside your car and call me from outside? And so now all my aunties got the big, it's still Motorola because they're the innovators, the big Motorola cell phone. And everybody walking around with the phone that's this big right here with the antenna up to here. And they're like, girl, where you at? Right? And so everybody's excited. Next slide. And then my grandmother, who is now, I think, 72, she was just as hip as she wanted to be. Not my mom's mom, my dad's mom. And she was like, listen, all my kids got these phones. I want one. But she was like, I don't want it that big. My cordless phone is big enough. I don't want it that big because I can't put it in my purse. I'm like, true, grandma, true. So she goes in, and here we go, Motorola again, because they're the innovators. They now have the Razor. My grandma just knew she was cute because she got herself a Razor. Okay. And she had to watch my mom with the car phone, watch my aunties with the Motorola flip phone. And now she's ready because she's seen that they don't have to stay plugged into the car. They can be in the store and call her from there. And now she wants one. But finally, they got one that's thin enough for her to put in her purse. Okay. Next slide. Then I had like my granddad who was like, I don't really need that. Like, if you need me, just call me at the house, leave a voicemail. But then finally he was like, I heard they got this computer phone thing. I think I want a computer phone thing. So my granddad is like, I'm gonna get an Apple. That is the version 1, Apple iPhone 1, y'all. I found a picture. That's what it used to look like. And my granddad just knew he was cool because he used to have like the hip thingy where you clip it on and it would spin around, and he'd be like, let me get my phone, right? And he just knew he was cute. But granddad brought us into like this century with the original iPhone. Okay. Next slide. Then there's my dad. He will never, ever, ever, ever get any type of cell phone. He's like, you can call me at the house. Like, he's not even like his dad, who's like, yes, I can get an iPhone. He's like, no, call me. If I'm home, I'll answer. If I'm not, oh, well. And yes, he does have like one of those phones with the rotary because he wants to be funny. And he knows we hate it. Okay, next slide. What does this have to do with preparing for leadership, preparing for, recruitment and sustainability, or supporting people as they transition over a change? Not everybody is going to be an early adopter. Not everybody is going to be team flip phone. You're going to have some people on your team who will never, ever, 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 ever like integrated care, if that's your goal. They will never like team-based care, if that's where you're going. They will always fight back and tell you, if you need to talk to me, you can come to my office at this time, only when I give you permission to open the door. Okay. You will always have people like that on your team. They are the laggards, meaning they will never catch on to the new thing. They want to do things the way they've always done it. They are the leaders of their own patients. It's my turf. My people do not talk to me. And then you're going to have people who are going to be your champions, who have seen organizations like Cherokee Health Systems do integrated care, seen us have leadership roles and things, and say, you know what, I want to try the flip phone. Like, let me try the flip phone. Like, it may be a little bit clunky, but we're going to try it because we know we can go back and ask questions. But you get people who are willing to try. And then they're the ones who amp it up and say, listen, I was just at Walmart talking on my phone. You should try it. But as they try, as they, iterate, it gets betterer and betterer. Yes, I said betterer. It gets betterer every time, and more people catch on. Okay. I do not recommend you spend a lot of your time on the laggards. Okay. Because they're just not going to do nothing different. You decide how you want to handle that. Okay. Try to find at least one or two early adopters, the people who are going to be your cheerleader, who will do team-based care in this new way, but then really put your focus on the early and late majority, because that's going to be the bulk of your team members. They're going to be the ones who need to be convinced. They need to see success before they're willing to try it. But here's the thing, you have to be okay with people being at different stages of adoption. You cannot introduce team-based care, integrated care today and expect everybody to be an early adopter. That's not fair. Okay. Because in the same way, not everybody went out and got them a Motorola flip phone, whether they could afford it or not. Not everybody's going to be into team-based care the way you're trying to introduce it. So you got to give people grace to be anxious. You got to give people grace to not like it at the beginning. You got to give people grace to mess up and to ask questions and to push back a little bit. We cannot expect them all to be early adopters. And if that is your expectation of change, you have failed already. Like, just to be real, you have failed already. Give people grace to get it at a time. But I tell you, if you get you a primary care champion, if you get a front office champion, if you get a nurse champion, I guarantee you're going to be successful, especially if the top supports this as well. But get those champions on board. They will be your early adopters. You're going to get the early and late majority before you know it. Okay. Next slide. And again, progress is not always linear. You're going to mess up. And again, I keep speaking generally because some of you are already doing integrated care. Some of you just want to move a little bit further. Some of you are like, we work in silos. I want to know how to work with teams a little bit better. Whatever your end goal is, it will not always go from left to right. Okay. We think it's just going to be, like that lovely, line graph that we learned in school, 1 to 1, 2 to 2. It's not going to be a straight line. You go up, down, around the corner, like dip down, break the line, then come back before you start moving. But if you notice, every single one of these examples, you're still moving. Okay. And that's what we need to celebrate. We need to recalibrate our definition of success, recalibrate our definition of change, and reward that change and success at every step of the way. There are going to be times when you're going to fall in the water on your bike. And I don't know how you ride a bike in the water, but you'll figure it out because that's how things roll. I love the one on the bottom. Like, we expect to go straight through. And then when we hit a problem, we're like, well, I guess I can't do anything else. I'm stuck. I can never get to my solution because my thinking is so rigid. I only know this one way. But that bottom one, there's a way you can go around it. You can probably climb over it. You can go the other side. There's so many paths to getting to your solution. If you allow that flexibility, hire people who are allowed to be creative, you're going to get to that solution. And there's not just one way. Okay, next slide. This is the last slide I'll leave you with before we transition to office hours, but I need you to recognize that when you're affecting change, okay, implementing anything new, first you learn to do it, then you learn to do it well, meaning you're gonna make some mistakes, then you learn to do it fast, and then you rinse and repeat. Okay, so you're not gonna learn to do it and then learn to do it fast tomorrow. You're not gonna learn to do it and then be really good at it tomorrow. You're gonna mess up a whole lot. And that's okay, because this is an iterative process. If you give people permission to mess up, that's how you retain them. If you give people permission to ask questions, that's how you retain them. If you give people permission to give you ideas and feedback for how to do something differently, that's how you keep them. We cannot just be like, nope, you failed, goodbye. You got to give them some grace. All right. So that is my last slide for you. It is that PDSA cycle. Yep. That's my last slide. I'm going to pass it back to Shannon, and then we will keep it moving.
Thank you, Ebony. Oh my gosh, that was amazing. Like, I loved it. You've gotten some great feedback in the chat, and people have dropped some things in the Q&A. So I just want to say thank you. This has been amazing. Before we transition into our office hour, guys, where you're able to, ask questions and have Dr. Winford answer them, please, if you could, just complete this post-presentation poll just to give us a little bit of insight, into how you're feeling after hearing from Ebony. Again, this has just been amazing and just such a wealth of knowledge, Ebony. So I appreciate you. And for those of you who have questions, I encourage you to drop them into the chat. or to the Q&A. I have some questions that have come in throughout the presentation that I've compiled, and I will be asking those. And I mean, just like the feedback, I mean, if you're looking in the chat, just it's amazing. Everyone loves your energy, Auntie Ebony. So and they're sad that the presentation is over already. We'll just hang on for just a little bit. We're gonna do the office hour. So you'll get some additional nuggets of information. And thank you, Kimmy, for advancing the slide. If you just want to go to the next one so we can have Ebony's nice, pretty slide, we can go into that, and I will start questions. So Ebony, in the beginning, you talked about like building excitement for your team. And someone dropped in the chat, should you, not include the patient or family in the beginning stages of this process? I know that you mentioned the patient advisory board and kind of like tapping into that, but are there any other ways that you could, engage with the patient, or do you see that as coming a little bit later on in the process?
I'm a big fan of community engaged everything. And so nothing about us without us applies even in healthcare. And if you have a healthcare advisory or patient advisory board, I think they should be at every table that you set up, because we're making plans and things for them. We shouldn't do it to them. We should do things with them. So yeah, bring them on in. And if you don't, you're not doing it right. And there are ways that we need to do it right. Like I know we failed at not having the patient voice at the table every single time.
And then we also have another question that's related to the also with building excitement, right? So you mentioned building excitement to just demonstrate that active support. And there's someone who dropped into the chat, if they wanted to reinvigorate rather than introduce the concept, would they still do a kickoff, or what strategies can they do to kind of, maintain that excitement or rebuild that excitement?
Yes, the answer is yes. Do it anyway. I've done a couple reinvigorating webinars for a couple organizations I've worked with historically who are like, we were on board, it was amazing, it was lovely, but we've had such turnover, or we have new leadership and now nobody knows what the heck they're doing. Can you please just come reintroduce it to us? And I do very similar to what I do here. I introduce what integrated care is. I tell them all the roles that different people can play. We go through this, right? Like, what are some things that go well? What's your goal? Where do you want to be? Where are you now? But I think it reinvigorates them, especially if they're people who used to do it and they remember, like, y'all, we used to do it this way. And then even people who are brand new and anxious, they're like, it worked though? And they're like, yeah, it does. So I think it's totally okay to reintroduce. You can frame it as, this might be a review for some people, this might be brand new for others, but let's just act like we're all learning it for the first time and just learn together.
Thank you. Another question for you. So to what do you attribute Cherokee Health Systems' success in implementing integrated care in a rural, mainly conservative, non-Medicaid expansion state, all of which might limit support as needed, but yet Cherokee has managed to build a successful integration record? Is it the people that you're hiring, consistency over decades, engaged patients? What in all caps is it?
What is it? So I can give you the real response is corny. So just hold on to that, okay? This state sucks as far as like the ability to promote wellness, to provide equitable access, to think about care in a collective sense. We are very individualized. Pull yourself up by your bootstrap type of place. And I still don't understand how you pull yourself up by your bootstrap. Like, it doesn't make sense to me. Either way, that's the water we swim in right here. Like, it's around us all the time. So it's up to us to disrupt that. And so the real answer that is cheesy is that if you ask any of us why we're here, we'll tell you it's because of the patients. If you ask any of us why we're here, you'll hear, because I believe in what we do. You'll hear us say, Cherokee took care of my family. And I want everybody to experience that. Like, we will tell you what you would think is the biggest fluff, but I promise you it's real. I promise you it's real. I will also say that there are things like psychological safety. You cannot be afraid to say, that's a really bad idea. Because there are certain environments where if you give feedback that somebody doesn't like, you get fired. I think we've created an environment where, like, if you don't feel comfortable telling one person, there's at least one other person you do, and you know that that person will advocate and speak up for you. But it's okay to be like, that's real stupid. I don't like that. Um, it's okay, but you'll hear that people really love what they do. Like, I never thought I would be in Knoxville, Tennessee, y'all, like, ever. Um, but I've been here going on 11 years, and I love what I do. And yeah, I think we love what we do. That's what it is. And I think I call myself a gatekeeper, and I'll just be real. Like, I don't want anybody on my team who doesn't feel the same way, which is why I ask the questions that I ask, which is why I look for the fit that I look for. I want people, even when it gets hard, like, whew, that was good. You know, like we had a patient yesterday, one of the realest versions of psychosis I've seen in a long time. It was rough and it was scary, but me and the PCP who worked together, at the end, we debriefed. We were like, y'all, we still got it. Look what we just did. Ooh, you good? Okay, I'm good. You need to huddle? Okay, we're good. And then we went and saw the next patient. And we would do it all over again today if that patient came back, because like we care. And so if you can't demonstrate care for people, especially in an FQHC who have been historically marginalized, disenfranchised, all the eyes, you don't get to sit with me. And I'm a gatekeeper in that regard. And I think because we are protective of our patients the way we are, like, you gotta be cool to play with us in order to provide that care. We're only gonna get people who live it. And of course, there are gonna be some people who fall through the cracks, but they don't stay for long.
I love that. Thank you. It made me think of something. So I'm going to ask one of my questions because I'm fortunate enough to know how many questions we have. So how do you balance that, getting the right fit, getting the right person when there are so many workforce shortages in healthcare, right? So
Yes.
it's like if you're getting only a few applicants and you're like, well, I need someone to fill this position, they may not be the best fit. How are you guys managing that?
Never hire out of desperation, ever. You will make the worst choice ever. Never hire out of desperation. Um, we've done it, and you pay the price, not just financially and the cost that it takes to onboard and orient someone, but we've had an example of like a person who decided they weren't going to document anything for like 3 months.
Mm.
We had to find that out. And how do you recreate documentation from 3 months? You don't. So we've disrupted continuity of care. Like, we have not fulfilled our contract. Now we got to go back and talk to the payers to see if we submitted a bill for a service we can't justify. It costs time, it costs sleep, it costs money because we needed a body. Do not hire out of desperation. I would rather like give up 2 hours of sleep than to have to go back and fix all of what was messed up because we hired out of desperation. And that's a hard place to be in. It's a really hard place to be in, to say, you know what, I would rather not have a person than to have a bad person. Because again, I'm a gatekeeper. Are you gonna hurt my patients? Because I get really Auntie Ebony on them. Like, you gonna hurt my patients? Like, for real. Like, I don't know what you did with this patient because you didn't document it. I don't want you on my team. And now we got to go back and audit everything because
Right.
you didn't do right. I just don't want you here if that's what we got to deal with. So I'd rather struggle, to be truthful, than to have a poor fitting team member. And sometimes we find out after the fact, and then we still got to go back and redo everything they've done for as long as they've been here.
Yeah.
It's not worth it. It's not worth it. I will say this though. I've had two instances in 2022 where I had to take unplanned, unexpected leaves of absence. Okay. They were 4 to 6 weeks each. One, I had the pleasure of taking care of my grandmother as she made her final transition. She was 92 years old. I was her 24/7 caregiver, right? And another, I had to have a major surgery where, I'm cut from my sternum down to my pelvic bone, not planned. When I came back from both of those things, not a thing was dropped that I had remaining on my plate. Every patient who was on my schedule who had to get rescheduled or canceled, they were taken care of. Any supervision I had to do of any interns or postdocs was taken care of. Any paperwork that I may have had to submit for a grant was submitted. Like, I didn't even know what was happening. I was able to be fully present and away because my team had me. Like, there was another time I got really bad news and I just left, but apparently I left my laptop, my notebook, my whole 9 yards. When I came back the next week, it was in my office. I don't know who brought it to me.
Right.
So when you have gaps in workforce, when you have missing pieces, the ones that are still there, like, we got to come together. And they came together for me. I still don't know who did what. Still don't know who did what, but they filled in the gap for me. Would I want them to do that all the time? Absolutely not, because I do a lot, y'all, but they did it all for me. But notice how strongly I'm speaking of, like, the team members. Like, it's that strong for me that even if we don't have somebody in that place, somebody will do something to take whatever load off that's there. And we don't have to be asked. We just do it. And if you don't have that environment or that culture, it's gonna suck. There's no other way to put it. It'll suck. So you got to cultivate that trust, cultivate the psychological safety, cultivate the relationships, such that people don't think twice about stepping in when there's a gap.
So I think
And
that
I don't
leads
know if there's an XYZ do it this way, right?
yeah.
Like,
No, I was going to ask you, so that leads to another question, kind of, facilitating that integrated care culture. Whenever you were presenting, you talked about, nurses being able to tag in team members without repercussions and, you know, pulling in your front desk team, your RCM team, and kind of like building that out where they're able to operate and do what they need to do without, feeling like they'll be punished or that someone's going to question their decision-making skills. Are there any ways that you can share with us on how you facilitated that or any strategies to kind of getting that? I mean, I've had that experience too, where I volunteered to sit at the front desk and I was just like, what even is happening? How do you, I don't even, how do you do this? How are you sitting behind this glass wall? Like, are you frightened? What's going
all
on? Are you
day.
checking insurance? It's all of these different things, but I think, what you said really, stood out to me as far as being able to, they have that autonomy, they can make decisions and they're not chastised for it. But I know a lot of organizations don't have that.
One thing I like to do, I think it goes back to the modeling, like when I see somebody who makes a change and we notice like the change is good, I'm like, who did that? That was good. Like, thank you for doing that. I'm like, we were wondering why things went smoother or like we were struggling and then something you did worked. So thank you. But like really showing value, honoring them and not punishing them. Like, I will brag on my people any chance I get. If they come up with a different workflow, we use Microsoft Teams. I'm like, y'all, shout out to Becky. We have our lead front office woman is Becky. I'm like, shout out to Becky. She created these new packets for us. We're test driving it. If it works, let her know. If not, we'll fix it. But like, reinforce the fact that she made a change without permission. And so any chance we catch people doing good, we do it. Like, we'll do staff shout outs in our biweekly all staff newsletter. This person saw that there was a backup with check-in or blah, blah, blah. So they decided to do it this way and look at the success we had. So we celebrate the successes. I'm very transparent, especially if I am supervising anyone, if I'm managing anyone. I say, if I do something you don't like and you don't feel comfortable talking to me, I need you to snitch on me. And here's the person you snitch to. Okay. If something is happening to you, I need you to snitch to me. And that way, if you don't feel comfortable addressing it, I'll do it. I'm not going to say who said it to me or whatever. I will keep the circle of trust strong, but like, I'll speak on your behalf. So we have to be willing to speak on people's behalf and to hear and also reinforce the good stuff they're doing. Like, listen, I love my people. I love my people.
Yeah. I
But
feel
it's
like
simple, but
that's mutual.
reinforce.
Yeah. Yeah. So I'm going to jump to another question. There's someone who shared in the chat that you made a great point regarding the strategic plan, being a live plan and noting that it will change as goals and challenges of an organization change. And the question is, how often do you recommend reevaluating a health center strategic plan?
We do it formally every 3 years. We do it daily, informally, like literally. But no, we do a formal strategic plan every 3 years where every team member, every person who works in this clinic does a SWOT analysis. We have over 700 employees, and every employee provides a SWOT analysis from their perspective, de-identified. We want to know what area they work in, right? Are you in the nursing side? Are you behavioral health side? But we want to know like the discipline you're in, but everybody does that. And then it's compiled, and then the results are shared with the organization. And the last one we did, which was in 2023, I think we just did one last year. We said, here's what we heard from you. Here's what we can do, what's in our control. Here's what's realistically out of our control. We are working to prioritize this. And then we kind of sent it back and said, hey, knowing that we can't do anything about this, let's look at this side. Like, which things do we need to prioritize? And I'll be honest, one of them was compensation. So our CEO has made a significant effort to give everybody some type of raise, because that was the #1 weakness that we had in our organization, is that pay wasn't comparable. And I'm no shame in saying that. And so she made a concerted effort to increase everybody's pay. And that was an opportunity for people to do it safely and not feel afraid to say, this isn't right. Because if we would have done it one-on-one, they may have been less likely to say it. But when we did it in that de-identified way, it was resounding. And so she knew she had her marching orders, like, we need to fix the pay scale. And so every 3 years officially, if we start finding that things are just getting clunky in the clinic, what's working, what's the strength, what's the weaknesses, what's changed? Do we make the change? Do we need to make a change? And PDSA in all day long, like literally all day long.
So I have another question for you from Debbie, who I just want to shout out for being engaged throughout the entirety
The
of it.
whole
I mean, like,
time.
you know,
Okay.
just going to town with engagement. So Debbie, thank you so much.
The whole time. I was looking at
Yeah.
it like Debbie is a real one.
Yeah, I love that. And so her question is, how do you make sure that your team is okay when they're having issues?
Yeah. Auntie Ebony comes out. Um, I am I'm thankful that in the time I've been here, I've been able to cultivate a place of safety for my team members. I don't think I've done anything specific, but almost everybody at some point has been on the equivalent of my couch, because they know if they share a concern with me, it stays with me unless they give me permission to share it. And so I'm thankful that over the years I've cultivated that sense of, you can come talk to me, but also you can ask one of the nurses here. She came out of her room the other day and her face was like this. And I was like, what's wrong? And she was like, nothing, I'm just smiling. I was like this? She was like, okay, something's not right. And so she came and told me, but I commented on it. Like, I didn't act like I didn't see it. I was like, that's weird. You don't look like that normally. And so make it okay to say what's wrong with you. Especially during the pandemic, especially when murder of people who look like me was more televised than ever before. I purposely say, hey, doing a soul check. What do you need? I may not be able to fulfill the need because I need somebody to take care of me and, check my soul, but you got to take it upon yourself to say, hey, I'm just doing a soul check. You don't have to answer. Give me one emoji to respond how you feeling. And I did a lot of one emoji check-ins. And then we developed a system of behavioral health leads, nurse leads, and then primary care leads, really informal. But we said, you know what? I'm going to take care of this clinic during the pandemic. You take care of that clinic during the pandemic. And so we each took care of the discipline in that clinic. And so we kind of just officially, unofficially became the soul checkers for everybody. And that built relationship with people I didn't know existed. And now they'll be like, hey, can I run something by you real quick? I got an idea. But it comes from the leaders. You have to extend the invitation instead of waiting on them to come to you. So one emoji check-ins works really well. If they want to say more, they can. But I ask and I'm nosy and I will onto you until you tell me leave you alone.
Yeah, awesome. That's a great takeaway because I think it shows balance, right? Like you kind of know where you stand with certain people, where you're able to have those check-ins, have those conversations. But then, as you're building that trust or building that circle, you're able to do those one emoji check-ins and get some feedback and kind of like gauge where people are, but it's also not super invasive, right? So it's like you're learning your team and you're building that trust. So I really like that. We have another question that is your financial position as an organization stable or sustainable? And assuming if, if it is, how long did it take for your organization to get to that point of financial sustainability?
We started seeing people in 1960. It is 2024. That's how long it took. But I will say we don't have one payment model. We have done lots of different multiple sources of revenue, blended capitation, value-based care, of course, fee for service, grants, prospective payment, FQHC funding, public health funding, substance use funding. Insert funding source here, we have it all. But I'll be honest, like we try our hardest not to depend exclusively on grants because they end. If we hire someone, even if it's to work on a grant, we will not hire them unless we know we got money to keep them on if the grant ends. Like we don't hire people just for grants. And that's another way to retain people, right? But our previous CEO and our current CEO did an amazing job at saving. Okay. There were times before I got here that they still share with me and got pictures to prove it, that our CEO would not cash his check unless every employee got paid. That's when paper checks were still going down. And he had this stack of checks on his desk that he would not cash until he knew every employee got paid. There have been times when the leadership didn't take their annual cost of living adjustment because they knew that people lower needed the money, right? And so they made equitable decisions. And so as long as you have leaders who are selfless versus selfish, you sometimes make really tough decisions to get to a point of stability. But you really have to diversify your source of income. So how many, value-based contracts do you have? We negotiate our exact data from our, the CBOs. We get it, or from the MCOs, and we want to know exactly what percentage did we meet on that UDS metric last year. So when we set our benchmarks for the coming year, we're setting them realistically in comparison to what we did already, because I've seen organizations where, let's say, their UDS metric might be to have, 97% of their people who have hypertension to have controlled hypertension. But last year you only met 30% of that. You have literally set yourself up to fail. You're not getting any reimbursement or any bonuses. You got to think smart, get your data and make data informed decisions about your money. Save as much as you can, invest as much as you can, and also have leaders who care, because I know that wasn't an easy decision to make.
So I think I'm coming up on the last question from you all who are still here. So if there's anything else that you'd like for Dr. Winford to touch on, just drop it in the chat, drop it in the Q&A. I also have some questions, so if we have time, I'll ask those, but do want to ask this one, that is, has Cherokee Health Systems deliberately built a historical record a la Hershey chocolate of how they've grown over the years and built an effective, for patient outcomes, a successful organization, and documented it so that outsiders could see the whole history and development and possibly learn from it? So what this person said was a kind of Cherokee museum.
Let's see. Let me respond to Pam. If you want a training, email me. Even if you go to our website, it'll link you to my email. So you can just email me. We don't have like a history book. What we have done is that we've been included in like exemplar studies, like where people will come interview us about questions like this, and then it gets included in their publications. Like AHRQ has their exemplar models of, team-based care, integrated care. We're documented in that. And a lot of what I shared here is documented there as well. But an official historical account has not been given except orally or in trainings. But I'm getting excited because I'm actually married to a historian. And so I'm like, hey, babe, like I might have something for you to do to get the history of Cherokee Health Systems, get our oral history, get our written history. But with the exception of like being interviewed and published in exemplar studies, for the most part, we have never written it ourselves. But that's a real good idea.
Thank you. We will drop Ebony's email in the chat. And then want to ask this question that just came in. Are any of your employees in unions? If so, how do you maintain equity with non-union members doing similar work? Thanks,
We don't
Ebony.
have unions.
Okay.
Yeah. We also don't have contracts. Like everybody is a free for all. Like you're not contractually obligated to work here. But no unions. At least I've never heard of any.
Okay. Thank you. So we have about 5 minutes left. There are no additional questions that I'm seeing. So just want to make sure that everyone has had an opportunity to ask questions. So please drop them in if you have them. And then Ebony, I want to ask you something that you mentioned. Let me see if this is a question. Oh, Debbie had the best time. Thank you, Debbie.
Right.
So, you mentioned, reorienting your team to integrated care, your APNs, and having that stump the chump session. What's something that they brought to you where they're like, this is our issue? I'm just interested.
They didn't know that there are things they could ask us to do. So for example, I have one of the physician's assistants was like, I triage, which is the best consult to give you. And I'm like, no. Like, give me everything. Like, I got you. Like, she's like, no, some of these I don't know if you really have time for, and I don't want to make you feel guilty or burdened. I'm like, sis, put everything in the chat. Okay. Like, I will triage. I let you know if this is something I can see right now, if it'll be like 30 minutes or if I need them to schedule. So I learned that they didn't know what was okay to send to me. I also learned that because they were hired in the pandemic, they never had this official overview. So they kept hearing integrated care and seeing other people do it, but they never quite knew what it was. And so that's even internally, y'all, the place that trains everybody. We have people internally who are like, what is this? And I think the biggest thing I learned from them is that they want us to be involved in care. They just didn't know they could involve us in care. And so I left feeling a little bit sad. I was like, y'all been here 2-3 years. You don't have to do it alone. Like, it's okay. But thankfully, I think I gave them like a script to use for when they need to tag us in, when they need to talk to patients, and hopefully they'll feel more confident with that. But I learned they didn't know enough.
Yeah, no, that's interesting. And great that you're having those sessions. So this, I think, will be probably our final question. Someone just dropped in the chat. We adjust off same day warm handoffs for the slide patients. If you schedule follow-up appointments with a BHC on the same day as another medical visit, do you charge for those same day visits?
We do the same for our slide patients. So like if they're on sliding scale, then we will slide the other service to 0. If they come back and return, there is a charge for each service they receive, because our PPS rate allows us, we can do same day billing in Tennessee. That's one of the things we do well health-wise. However, we will never, ever refuse to take care of somebody because they can't pay us. Okay, so like we have to drop the charge, but we will never turn somebody away because they can't pay us. And I say that very explicitly to patients. I'm like, do not let money stop you from coming in and getting help. We will take care of you. Whether you give us a penny or nothing, show up. We want to see you. And that's another testament to like the work that our previous leaders have done to establish financial sustainability. We can say that with confidence and be okay.
Thank you. Last question. And this is from Florence. Can you share with us your staff turnover rates? She imagines that they're low. So I'm not sure if you.
It depends on what area you're working in. Our centralized access, which is essentially the one spot where it's essentially one big front office that has the highest turnover. Because look at what they're doing all day long, answering calls and transferring and answering and transferring and scheduling. That's why we have this new scheduling system that we're using, because we recognize that was our area of highest turnover. So the scheduling system that we're using, they've been using it for a month and they love it. It's less demand on them. So we had to make a change, and the whole organization got to change things, but we're hoping we can retain the ones who have turned over so much in the past.
Thank you. Thank you all so much for your questions. Thank you, Ebony, for answering my questions. Just want to share with you all that there is an equity in action session that is coming up on March 14th. The link to register is here. You'll receive this in your email when you get the slide deck. The focus will be on enhancing maternal health outcomes through integrated care for women of color. So I encourage you to check that out. There are a few other trainings here and resources that are available on the COE website. Next slide. And if you have any questions for me, please reach out. My email is here. I've enjoyed all of you. Thank you so much for attending. Thank you, Dr. Winford. I know I go back and forth between Ebony and Dr. Winford, but thank you. I appreciate you. This has been amazing, and I'm just grateful for you being here with us today. So we will wrap up, and I think Maisha has dropped or will be dropping the evaluation survey into the chat. You'll also receive it via email. Please share your feedback. We want to hear all of the good things that you're saying about Dr. Winford that you dropped in the chat, and make sure it's formally documented. So thank you guys so much for attending, and we are done.
Thank you for having me. You have a great day.
You too. Thank you.
Bye.